All right, to all who are new here, welcome. Due to COVID-19, we have moved our regularly scheduled in-person journal clubs to an online platform. Fortunately, our fearless head of the journal club and liaison with the BOC, Brittany, has been doing an excellent job at making this a seamless and very effective transition. We have over 200 athletic trainers today registered for the webinar. For additional webinar educational opportunities, you can visit our website and register directly for the webinar, or sign up for the email list to be notified of upcoming webinars. For all athletic trainers who are intending to get live CEUs from the BOC, immediately after the webinar, complete the quiz, which will become available once the webinar has finished. In order to access the quiz, you must remain in the webinar until it closes. 1 hour after the webinar closes, you will be emailed a link to the evaluation and assessment. You will have 24 hours to complete the assessment. Once you've completed the quiz and the assessment, you will receive your statement of credit via email in a timely manner. If you have any questions during the webinar, please submit the question in the question tab, and we will review the questions at the conclusion of the presentation. So I'm very thrilled today to introduce our speaker. Dr. Rathna Nuti is a sports medicine physician who completed her medical school training at Texas Tech School of Medicine. She completed her residency at UT Southwestern, followed by fellowship at Drexel. Since then, she has worked at a variety of practices and practice settings, along with a variety of sports, including hockey and ice skating. Today, we are thrilled to have Dr. Nuti present on primary care prevention and management of football injuries. And I do have to make a correction, as she does work at Sport Orthopedic and Rehabilitation. Take it away, Dr. Nuti.
All right. Thank you, Michelle, and thank you, Brittany, for organizing this and hosting me for today. I'm very excited to speak to you guys with regards to primary care prevention and management of football injuries. I am associated with the Dallas Stars as well as the Dallas Stars Ice Girls. So I know right now with COVID-19, a lot of sports have been in halt, but one of the things that has been in discussion at this point in time is whether or not we would be ready for football season. And now typically would have been the time to kind of ramp up training and get together. But obviously, because of certain circumstances, that has been put on hold. But either way, I think it's important to be prepared when things do start to reopen, how we are going to manage that as medical professionals. So I have no conflicts of interest, and want to talk about the goals and objectives is going to be that we're going to talk about pre-participation physical exams, history, the exam itself, common football injuries to anticipate, such as shoulder, hip, knee, and ankle, as well as concussion prevention, management, and treatment thus far that we have in literature. So to start off with, we always talk about who and what consists of an athlete, and it's basically an individual who regularly exercises or in training or in general fitness. For us, it's basically the athletes that we take care of, whether it be for high school teams, whether it be for professional teams. Regardless, everyone is trying to be active and engaged. So they all come in different shapes and sizes, ranging from kids to adults, and obviously at different training levels as well. So I have a case scenario to kind of make it a little more interactive and not to make this talk a little more dry and boring for all of us. So for example, you have a 17-year-old African-American high school all-star quarterback who comes to you and he needs a form filled out for school, typical to play football because a lot of schools are requiring pre-participation exams. He has goals to play college football and on an athletic scholarship and looking to get scouted. So his medical history consists of that he's a controlled asthmatic, has had a concussion, has had 2 broken ribs. Surgical history-wise, he's had an ACL done about a year ago from a hamstring autograft. Family history is that his father died for unknown reasons before the age of, at least the age of 40. And socially wise, pretty clean kid. And allergies, typical pollen seasonal allergies that we think about. Meds wise, he takes a albuterol inhaler as needed. Again, keep in mind that he's an all-star quarterback, and a lot of parents will come and drive you a little crazy with regards to this, especially I know here in Texas, that's a big deal here. Vital signs wise, he goes to office and gets vital signs, and it's 140/90, heart rate of 60, typical 6-footer, 210-pounder. Physical exam wise, he has a murmur that is 3 out of 6 in the left sternal border that gets loud with Valsalva, and his lungs are clear. So question comes down to, should you clear him? Is this a kid that is of concern, and what should you do? So we're going to start with a pre-participation physical exam. So first of all, there's a question of how should it be done? Should it be done in a mass setting, like a school, big school gym, and everyone comes through and gets goes to different stations, or should it be done one-on-one with offices? And actually, the question is not a question anymore. We are recommending that these kids go to their either pediatrician, family medicine doctor, or sports medicine physician and get a pre-participation physical exam one-on-one. And the reason is the mass settings are that where you're trying to get through a huge group, you're trying to get through a huge number in a timely fashion, and things can get missed. And of course, everyone's wanted to go to station and get checked off. So your ability as a provider to actually talk to the athlete more one-on-one and with their families is actually limited in a mass setting, and the privacy aspect is also not there as well. So to kind of give you a classification of sports by physical intensity, just know this is a common diagram that is given out there, and more times than not, the American football is in the middle section here. Let's see if I can show my pointer here. And that's a big focus of our topic for today, in wanting to know where all this falls into. So pre-participation form actually has undergone a lot of revisions, and one of the revisions is the updated form found in the new monograph. It's no longer the 4th monograph anymore, it's the 5th. And basically the questions were slightly modified to have it where it's a little more involved in terms of the mental health aspect. So these forms actually should be filled out by the parent and the athlete together before seeing a provider, and not on the day of the visit itself. So some recommendations. When should we actually conduct these physical exams? It should be approximately about 6 weeks before the activity. So that way it gives them plenty of time. If other testing needs to be done, such as MRIs, EKGs, all this can be done before the season starts. And these kids can start their seasons pretty in a timely fashion as well. All athletes undergoing these exams should be questioned about exertional symptoms. They should be questioned about their heart murmur, symptoms of Marfan, whether or not there's a family medical history, and it takes a lot of teasing to kind of bring out these questions. And this is why another reason why mass settings are not ideal for this. When it comes to blood pressures, biggest question, because our athletes have, I mean, in general, low heart rates because of their fitness levels, comes to whether or not what should be acceptable in terms of their blood pressure. So anything where the blood pressure is less than 160 on the top number and as well as less than 100 on the bottom number, they should not be restricted from playing sports. They actually should be in consultation with their physician and whether or not what is acceptable. As well as athletes who are controlled asthmatics who are asymptomatic at rest and with exertion, and keyword is and. A lot of times we kind of brush it off if it's asymptomatic at rest, but when they're exerting themselves, that's another key factor to kind of keep in mind as well. Another thing is screening blood and urine tests are not recommended for asymptomatic athletes. There's honestly no reason to, unless there is a medical, the caveat is unless there's a medical reason to screen, to do a blood screen or urine screen, that's when you need it. But other than that, you don't need to implement a wide rule on this one. Another part of the Choosing Wisely campaign, so what that is whether or not certain tests need to be done, and if so, and to what degree and extent. So first of all, just know there are a couple of organizations, AAFP and ACP, who who recommend that you do not order annual EKGs or any kind of cardiac screening for asymptomatic low-risk patients. Now, keep in mind, the caveat is asymptomatic and low risk. And AAFP also says do not screen adolescents for scoliosis. Now, AMSSM basically comes back when it comes to a cardiac screen, saying that every physician has their autonomy to assess whether or not an EKG or further cardiac imaging is needed, and that's only if it's for a certain population or certain community resources. But again, that's more of a one-on-one discussion that needs to be done. And keep in mind, one thing to emphasize, I think, from a medical provider standpoint of view, as well as an athletic trainer standpoint of view, is that we need to let parents know that it's just because we screen them, it does not provide absolute protection against having sudden cardiac death or sudden cardiac arrest. There should always be an emergency action plan and access to an AED. Always key, and within reach and availability more than anything else. So when we come to EKGs for an athlete, the way we go about interpreting EKGs is definitely different than how we interpret EKGs for the normal population per se. And there is an international consensus standard and criteria, and a lot of these criteria has undergone a lot of revision. It used to be the Seattle criteria that we referred to, and now it's the international consensus. So you can already tell this criteria is evolving, and who knows what will come up before or after certain things happen. So just know that for now, it is the international consensus standards that are utilized to interpret these EKGs. So good summary is that PPE should be conducted in the office setting. Understand your athlete and the type of sports that they're involved in. And a lot of times these athletes are not just involved in one sport, so there's multiple ones, so to keep in consideration. Know your athlete's medical history and previous sport injuries. Use your clinical judgment and discretion when you're doing cardiac evals in your athletes, and know that not everyone is at risk and not everyone needs an EKG evaluation. And if an EKG is needed, you need to consult with your sports medicine specialist and most likely sports cardiologist for interpretation and further management of that athlete. And know that the overall role of the PPE is to evaluate the health of the athlete to optimize safe sports participation. We want them to be active, but do it safely. So then we talk about what's the common football injuries. So breakdown of our football player here. And I'm located in Dallas, so of course, go Dallas Cowboys. So with our quarterback here, common one is, of course, you can get a concussion, you can get shoulder injuries, we can get hip injuries, knee, as well as ankle. So I'll talk about these in further detail here. So when we come to the shoulder, let's talk about the shoulder first. So we can have glenohumeral instability. So what that means is this can be partially or completely destabilized, the joint itself. As you know, the shoulder joint is not the most stable joint of our bodies, just as compared to the knee and hip. You can, most times than not, you're going to have an anterior dislocation of the shoulder because these athletes, when they throw the ball or the position of their hand is usually an excessive abduction as well as extension and external rotation. And that's the reason for this instability when it happens anteriorly. So here's to kind of highlight that a little bit here. Most times than not, you'll see this in your offensive linemen. You'll see posterior instability. That's because they're blocking with their outstretched arms and repeatedly loading that joint capsule there. And here's a prime example right here to kind of show you that in pictures. I like pictures with words. It kind of gives you a little bit better visualization when you're talking about these kinds of injuries. So you can see the athlete's going forward, his shoulder's going backwards, and there's that instability there. All right, so one exam, what would you see? So you would see a positive apprehension sign. On x-rays, you can see a Bankart lesion and or Hill-Sachs lesion, and this is the white arrow is pointing to the Bankart and the black arrows are kind of pointing to the Hill-Sachs there. So try to find an x-ray to kind of put it both together for you here. On MRIs, if they progress to that, then you'll see slap tears. So here's the labrum, here's the humerus, and you can see the dye kind of leaking out of that labrum there because there's been a tear there. Treatment-wise, usually non-operative management, if that is determined, it's usually 12 to 16 weeks of therapy that we're really looking at. The sling for maybe 2 weeks, aggressive rehab, and modification of lifting techniques for at least 6 weeks to 3 months. That's the time frame that we're really looking at. If the athlete is determined that he needs surgery, then it's 4 to 6 weeks in a sling plus a post-op rehab plus waiting several months before weight training. So just kind of giving you the time frame. Again, every athlete is a little unique and individualized. Plans are recommended, but this is the general concept and time frame that we're looking at. What about return to play? Well, unless the athlete has full strength and range of motion, and it's also dependent on the surgery itself, you need to have that consultation with your with the surgeon who's done it in order to get the full clearance before you can kind of start getting them into the return to play type of action. So AC joint sprains, that's another common one, also known as a quote unquote separated shoulder. It's basically when you're striking another player with point of the shoulder or landing directly on the point of the shoulder in terms of tackling here. And of course, this Steelers guy took that brunt of the hit there, as you can see. On exam, you'll usually find tenderness palpation of that AC joint, and sometimes if it's drastic enough, you may feel a step off on that. On x-rays, you can really examine the degrees of AC separation. This is just a compilation of like the different types you can get and the degrees that we're looking at. And not all of these are surgical. With type 1s and 2s, you can typically get away with non-operative management, but usually it's the 3s and above that may actually require intervention per se. Treatment-wise, usually non-operative-wise, we're doing a sling for 2 weeks, but in that 2 weeks time, we're actually having them do pendulum slings, getting out of the sling so they don't stiffen up too much, and then of course extensive rehab afterwards. Surgery might speed up recovery time, but then again, it depends on the type of joint AC sprain that you're having at that point. Again, it comes down to the question of return to play. They need to be pain-free, have full strength and range of motion that needs to be regained before anything can be considered further. And of course, if they have surgery, it's always dependent on the surgeon. Hip pointers, moving down to the hip. It's basically a contusion or separation of the attached muscle fibers at that superior iliac crest. And these are some of the areas here, and you can see how that impact may happen. So management-wise, there's usually aggressive icing, stretching of the low back and flank muscles, additional protective padding is advised. Local modalities, you can do ultrasounds, steroid injection, PRP. Again, return to play is they have to be pain-free and functional. Hamstring injuries. Typically of the mid-substance of the hamstring musculature, that's where we're seeing these types of injuries here. It can range anywhere from a partial tear to having edema to having bruising. It's associated with the sprinting motions, explosive acceleration, deceleration, or changes in direction, and that's very common in the sport itself. And the athlete typically limps, holding the knee in mid-flexion, and obviously loss of knee extension. Range of motion is usually noted. And here's our New York Giants guy kind of giving you the classic sign for that. On exam, you'll find there's tenderness to palpation of the area, possible defect, depending on the extent of the injury. There can be impressive bruising and edema. Again, it depends on the extent of the injury again. Management, usually up to 6 weeks of healing process. You can do acute injury modalities, rehab for range of motion and strength. Return to play really depends on the player and the healing time. There's not a hardcore timeline on these, and hamstring injuries, as you guys know, are very difficult to treat because it is one where we have to rely on the player and their objective exam of whether or not we can determine what's their safety in returning back into the sport itself. ACL tears, very common. It's the most devastating knee injury. You see some valgus loading of the slightly flexed knee, creating significant shearing forces of the ACL with a resultant tear. And here's a drastic example of one right here, sustained by one of the Redskins guys. Majority are non-contact injuries, not necessarily you have to have a contact. And contact, if it is, it happens when they're blocking or tackling. They can have significant pain. These athletes will definitely let you know about that. They will feel a pop or sense of tearing inside the knee, have immediate swelling. That's one of the keynote signs. There's subjective instability of the knee. Positive Lockmans or anterior door test on exam. And it generally requires surgical intervention in these competitive athletes. They have graft options, whether if it's bone, tendon, bone, hamstring tendon, or cadaveric grafts, sorry. And usually in these athletes, the cadaveric grafts are deferred because of the high re-rupture rate. But again, another conversation to have with the surgeon who's actually doing this surgery itself. Usually there's 6 to 9 months of aggressive rehab and functional bracing. Return to play, they're typically out for the season, and the athletes know this. And because once they feel that sensation that they have actually torn that ACL, they automatically know they're done because it's a long recovery process. Ankle sprains, just kind of focusing on this as well. There's a lot of ligaments in terms of the lateral side and the medial side where you can potentially have these. Ankle sprains, usually the ATFL is the one that's commonly injured, as well as the deltoid and CFL as well. So lateral ankle sprains, it's a result of landing on a plantar flexed and inverted foot. Usually these athletes are running on uneven terrain, stepping in a hole, stepping on another athlete's foot during play, or landing from a jump in an unbalanced position. And you can see one right here. That's obvious. The other one is the syndesmosis of the ankle sprains. If you have that, it's usually called a high ankle sprain. It's a result of a forced external rotation of a dorsiflexed foot, or during internal rotation of the tibia on a fixed planted foot. There's usually a direct blow to the back of the ankle while the athlete is lying prone with the foot in external rotation. And here is where you can kind of see that with our Patriots guy here. Medial ankle sprains. Medial ones are the result of an external rotation or eversion. It's isolated, rare. It's usually accompanied by a lateral malleolar fracture and or syndesmotic injury, as well as deltoid ligament. So here's a classic example from a Green Bay Packers guy. So an exam, usually regardless of any kind of ankle sprains that are sustained, you'll see swelling, bruising, positive anterior door test, and positive talar tilt test, positive squeeze test maybe, and positive external stress test as well. Imaging, you kind of follow the Ottawa ankle rules, seeing where they're tender to determine if they need imaging. If you're a high professional athlete, you're most likely going to go ahead and get these rules are going to go out the window, and you're already going to go ahead and get some x-rays on these guys. So here, kind of revealing what these Ottawa ankle rules are here. And treatment-wise, usually PRICE, which is protection, rest, icing, compression, and elevation and rehab. That's the most important thing. Injury prevention is usually looking at balance training. Prophylactic bracing is kind of a debatable questioning, whether or not that really does help. There is literature that is debatable, saying whether or not there's some literature that does say it is good to do prophylactic bracing, but then there's other literature that argues against it. So it's kind of up in the air on that one. Return to play. Based on the type of ankle sprain sustained, you're looking at a timeline anywhere from 11 days to about 26 weeks. So it really does depend not only on the athlete, but the type of injury that's there. But my strongest recommendation when these athletes have these sprains is to immediately go ahead and get them into rehab. The sooner you do, the better for the athlete. So in summary, common football injuries that are sustained are glenohumeral instability, anterior more than posterior, AC joint sprains, hip pointers, hamstring injuries, ACL tears, with non-contact being more common than contact injuries, ankle sprains with lateral one being more common than syndesmotic and medial. And that will segue into our concussion portion here of the talk. So what exactly is a concussion? It's a traumatic brain injury, or TBI, that's induced by biomechanical forces. It may be caused by either a direct blow to the head, face, neck, or elsewhere on the body with an impulse force transmitted to the head. So basically, the head moves forward in velocity, but the brain basically gets joggled in there. So inside the skull itself. And it results in a rapid onset of short-lived impairment of neurological function that resolves pretty spontaneously. In some cases, signs and symptoms may evolve over a number of minutes to hours. So it's not necessarily straightforward in terms of diagnosis. And it may result in some changes neurologically that where actually these abnormalities are not really seen on neuroimaging studies. So a lot of these athletes will ask you, well, can I get, well, if not the athletes, the parents will ask, well, can I not get an MRI? Can I not get a CT scan? Answer is no. The more important thing that you're doing with a CT scan evaluation is making sure that athlete did not sustain a brain bleed. But other than that, not really that it's utilized to diagnose a concussion. It may range in a clinical signs and symptoms, and it may or may not involve loss of consciousness. The resolution of the clinical and cognitive features typically follows a sequential course. In some cases, these unfortunately may be prolonged and they run into the post-concussive phase. And the clinical signs and symptoms cannot be explained by drug, alcohol, or medication use, or other injuries, or other comorbidities. So you can kind of see how we're already running into a gray area with this topic. So just wanted to give you a visualization of like common signs of concussion, symptoms of concussions that athletes may complain about. And initially they may say, hey, I'm not feeling anything, I feel great. But if you'll find that over the course of multiple hours or even after the game that night, that's when the symptoms may pop up. So it's good to let the parents know what to kind of look out for. And parents are very great because they're with the kid 24/7, so they pretty much know what is common for their child and what is not. So we use the SCAT-5 evaluation tool to kind of assess for concussion, and just wanted to throw in some visuals with regards to that. So if we look, there's a section on symptom control or symptoms that the patient is feeling, and that should be filled out by the athlete. And it's always great to have that on the day of the injury as well as post-injury as well, so you can have a comparison of where those symptoms are going and how severe. Of course, the evaluation portion is there where we look at orientation, immediate memory, concentration, and neurological screen, as well as a physical exam. And that kind of also helps you kind of guide whether or not what's the decision-making process. And as you know, as athletic trainers, you're more involved with the athlete than we are as physicians. And it's great to get your input because you know what these athletes' backgrounds are like and what how they respond to you, what they're doing. So getting that feedback from you guys is very important for us as medical providers, so that way we can kind of put the whole picture in a complete setting as well. Advanced testing. Well, there's advanced neuroimaging for CT scan, functional MRI, DTI, MRS, and CBF, but these are all research oriented. So same with fluid biomarkers. They're looking into blood, saliva, and CSF markers, genetic testing. And again, this is all research oriented, not necessarily at this point in time utilized for clinical evaluation. Treatment-wise, there's currently insufficient evidence of prescribing complete rest. We basically allow for brief rest of 24 to 48 hours after injury, but afterwards we actually want them to get back into their daily life. And that is where it's a battle with parents as well as athletes, because sometimes the athlete is the one who wants to go back to sport and you have the parent encouraging that, but pretty much our guidance is that they need to go back to school first before they can go back to physical activity. So, but good thing is most individuals recover in 10 to 14 days. Rehab-wise, you can look at psychological, cervical, and vestibular rehab. I'm a firm believer on the vestibular rehab in implementing that early, by early meaning like maybe after a couple weeks or so, if the athlete's still having symptoms, to kind of help in their recovery process. And my whole goal is to kind of prevent them from going into a post-concussive phase. If they are unfortunately headed in that direction, there is aerobic exercise testing that you can do. There's Buffalo treadmill as well as Buffalo bike testing to see at what heart rates we can push these athletes to exercise, because also exercise also does help, but not the exercise that is recommended for sports. So there is this fine line difference on that, and explaining that to the athletes is very important and key as well. what do we do about if the athlete has ADHD or depression medications? Is fish oil a good idea? This is still up for debate because at least for ADHD medications, if these kids are not in school and not doing homework, do we really need to medicate them? So that's a good conversation to have with the parents and with the kid as well. And fish oil supplement, I say, you know what, it's a supplement. It's not going to harm them, and if they want to try doing that, that's great. I know there is a research study going on right now as we speak that is being done by Dr. Miller here at Texas Scottish Rite, looking at high doses of fish oil supplements in the recovery aspect with regards to concussion. So we're still getting some information with regards to that. So as you can tell, treatment plan goes in so many various directions, and not every treatment plan is the same for each athlete. So like I mentioned before, we need to get them back into school first before they can return to sport. And this is the stages that we kind of go through and look at. But main thing is they need to be in school full time like they would as a normal student before we consider return to sport. And I think getting that emphasis from both not only the physician but also the athletic trainer is helpful, because a lot of times if the physician is saying, no, he needs to go back to school, and we're not getting that same reinforcement, then it kind of puts us odds at end. And of course, the parent and the athlete both get frustrated. So I think all of us being on that same page is very helpful. As far as return to sport goes, we start anywhere from stage 1, which is symptom limited activity, to full on return to sport. So, and I usually tell my athletes that that is between you and your athletic trainer, because you guys work with them pretty consistently, and I know the protocols that my athletic trainers go through, and I trust them. So once official clearance is needed, usually the athletic trainer just lets me know, and I see them back and say, yeah, you're good to go, and give them the full clearance at that point. So prevention. There's been talks of having helmet, mouth guard, shoulder pads, and cowboy collars, as well as vision training in collegiate players, evaluation of fair play and stricter reinforcement. Banning spear tackling is one aspect. So here's an example of one. So concussion-wise summary, it's a type of traumatic brain injury. Diagnosis is made simply by clinical presentation, and imaging is not necessarily required. You need to have weekly follow-ups, and that's very necessary and important for monitoring signs and symptoms and kind of knowing where this progression is going. You have a customization of the treatment plan for the individual, and again, athletes must tolerate school first before engaging back into sports, and I can't emphasize that enough as well. No equipment at this time prevents concussion, but definitely utilizing it is to help further sustain devastating types of injuries. So let's go back to our case scenario now that we have that information, back to our all-star quarterback here. And so the question comes down to, would we clear him? And honestly, at this point, I would say with regards to the vital signs, we can monitor him. With regards to his medical history, probably not. And so this is a great candidate where maybe doing an EKG and having a sports cardiologist involved to determine whether or not an echo is needed is necessary for this individual. Here are some of my references for this talk. And at this time, I'll open up for some questions, comments, and any suggestions that you guys have. Thank you.
All right, very good. So I'm getting the question tab pulled up. And so if you have any questions, please feel free to plug those on in here, and we'll get through as many as we can before our allotted time is finished. And thank you, Dr. Nuti, for this excellent topic, very timely, certainly. I know we were talking about a lot of the PPE stuff related to COVID. I do think there are going to be some questions related to what should we expect to see as we move towards the fall season.
Right.
And kind of in that vein, we did have a question come up. So is there anything coming out about PPEs for post-COVID-19 or return to play post-COVID diagnosis? So I guess if we were to split those up and talk first about PPEs as it relates to COVID-19. And I'm not sure if you were able to get in on any of those AMSSM team physician meetings this week, and I know there was a fair amount of discussion about that, so I can add that in if you weren't able to make it to those.
Yeah, that's a great question, and that's one that's still up for debate. And actually, you bring up a good point, because AMSSM is in the works right now to come up with at least a brief document for guidance of what to do pre-participation wise post with COVID-19 being around and the pandemic being around. And hopefully we're hoping that this will go away, but we don't, obviously the timeline of things is definitely up for debate. And yeah, I did actually get in on the AMSSM virtual meetings this weekend, and they've been really great. So at this point in time, as far as return to play and what we're going to do, it's really at this point we're thinking that maybe we should consider going through a PPE itself. But as far as the timing of things, that's what's still a little unclear for all of us. And we're trying to figure out, hopefully in the next few months, we may get a little bit more clarity, so that way we can kind of implement some strategies and how we're going to go about going back to sport, how we're going to reopen sporting activities in general, and what those implications are for the athletes, because we can't keep having athletes doing all this training and then decelerating and then ramping up again, and it's more prone for athletes to get injured when you do that, doing the whole back and forth. So I think that's a great question and a loaded one for sure, with unclarity up there as well. And Brittany, if you have anything to add into that, please go ahead.
Yeah, so I'll tell you the Florida experience thus far. I've been in close contact with our county athletic director, as well as our SMAC, the State Medical Advisory Council. And one of the things that are coming out in Florida, and each state is different, each county is different. We know that things are going to be addressed regionally, county-wide. And what we're talking about in Florida right now is going away from our typical mass physicals. What does this mean? This means that if we're going to do our physicals in more of a office-based setting, it does mean that it takes more time. So there needs to be more time allotted to be able to get through all of these student athletes. It does mean that there's going to be more transportation issues, right? If you're dealing with a high school, you're going to be centrally located. Many of those kids can get to school by riding their bike or however, whereas you kind of loading up and coming to a clinic, there can be more difficulties with transportation. But for us, it has been said already, and we're already ramping up on how we're going to do a much larger amount of PPEs in office, rather than what was normally going to be addressed via mass physicals at the schools. The other thing I wanted to bring up from there was the collegiate team physician meeting. There's a really nice document out there called Opening Up America Again. It's on it's at whitehouse.gov as the website. And what it does is it walks through what our phases are going to look like. There's 3 phases in terms of what a lot of the state and county governments are looking at. They're looking at this document, so we want to make sure that we know what to expect, so that when athletic directors and coaches and players are reaching out to us, whether that's as sports medicine physicians, but when you're frequently the ones on the front line as the athletic trainers, people are asking you, when are we expecting that again? And in that document, they are talking about phase 2. Those criteria require that we have in appropriate numbers of testing, that the healthcare system is adequately prepared to accommodate COVID cases. So those are some of those criteria. So long as we're able to continue to maintain that, and then maintaining the same amount of cases, if not decreasing amounts of cases, then we're able to progress to the next phase. And phase 2 is when schools and organized sports are recommended or suggested to reopen. So hopefully we'll get to that before we get to the fall.
Right, and to kind of add on to that, Brittany, I know in the state of Texas, and I'm guessing we can kind of say this for other states as well, at least there is a big push for PPEs to be done in office settings. And yes, you bring up some good points in terms of how we're going to go about doing that, especially when these kids have easy access to come to a school than to come to a doctor's office. And that has been a big, huge debate as well here. I know, and I know that also mass sports physicals are still going on throughout the country, and it's even AMSSM has put out a position statement with regards to that, but yet there's still some of those going on, and it's debatable because, again, like if something goes wrong, God forbid, for that athlete, that physician at that particular time, even if it's a mass setting, is responsible for that evaluation of the kid. So there's a lot of, from a legality standpoint, there is that, but then you do come across these social barriers of, well, how do we get the kid to the office? Is there an effective way? And I think that is still being discussed as well with regards to that. And I completely agree when it comes to mass physicals that you kind of shift away from that and actually shift towards this, but how do we address the other aspects of it?
Yeah, good point. All right, so I'm going to go through, and this is Dr. Henning here. I end up with Brittany's title on my screen. Another question is in regards to what is your preference, Dr. Nuti, on vestibular training? Do you have certain particular activities, certain rehabilitation that you want them to go towards if they are doing vestibular therapy?
So actually, the answer is long story would be no, I do not. The one thing I am very particular about is knowing who my vestibular therapists are and what kind of training they've had. I think majority of them that I've worked with at least have come from great backgrounds, because I know a vestibular therapist who actually got the training done at UPMC, and as we all know, that's one of the top areas in terms of sports. So no, I think knowing how that therapist goes about their protocols and how they update you. I think the most important thing is having that communication is very key for me. And if I'm able to get that communication, I think any vestibular therapist, regardless of where they come from, I think that is very helpful, because one, I can know where they're actually progressing and whether or not the story matches up to when the athlete sees me in clinic, because I've had I can tell you countless number of times, and I know Michelle, you'll even agree to this, is that athletes will tell you, yeah, I'm fine, therapy is going great, can I go back? And when you have a therapist, vestibular therapist going, yeah, he still can't track well, he can't balance well, he's having some ocular motor issues, then I know the kid's lying to me at that point. So I always tell the athletes that one of the things is I always communicate with my vestibular therapist and the protocols that they go through. And I know some, at least in Texas, I know some are actually verified to do buffalo treadmill testing or buffalo bike testing. And I actually sit down and review with them like how they're doing it. I think that's the key thing, because if you don't know what you're doing, just like even a medical doctor who doesn't know what they're doing, then you're putting that kid at risk and at danger. So I think sitting down and having that communication with them with regards to their protocols and what kind of how they're running their protocols, I think that's a key important thing. But as long as you have that confidence, and it goes kind of both ways too. Therapists needs to also trust me and my judgment as well. So I think that's going to be important, and that's what I really look for.
Yeah, awesome. I definitely agree with you. I frequently, if I'm having a challenging case and they just don't seem to be getting better, I do often use the vestibular therapist as well. I know in a lot of the collegiate as well as professional settings, as the athletic trainer, you're the one who is involved the most with the rehabilitation. And so if you are finding things like convergence insufficiency or unilateral vestibular issues, then the things that I've often gone to are things like the Brock strings. That's the strings, beads on a string. Pencil push-ups are another one to help with convergence insufficiency. There are all quite a few saccadic-based exercises, smooth pursuit exercises, the times one exercises. You got an X on a card and you put that up against the wall. Now you're turning your head, keeping that X in focus. So there are some definitely things that you guys can do as part of your rehabilitation. Those would be places to start if you're not already doing that as part of your rehab. So moving on, there's another question here about acclimatizations and reacclimatizations as our athletes are coming back to sports. What are your thoughts on duration of time? What should that look like? I'll put that one out to you.
All right, no problem. The duration of time, I think, just speaking wise, I mean, I to kind of give you my background, I basically have been in the state of Texas for over 20 years, and I have seen how things are done in Texas with regards to football is 100% different than how football is done up in Pennsylvania, where I did my fellowship. And I think it depends on, one, the climate and the heat that is there. So I know that our Texas summers are ridiculously hot, and we will get up to even in the high hundreds as well and beyond. But depending on where you live in Texas, you can have anywhere from wet heat with the humidity to dry heat. And I think if you're in a place like Pennsylvania, then you have humidity all around, so your heat is a little bit different compared to what is here in Texas. So I think wherever you are located and nationally wise, I would say the duration and time period is going to vary depending on what you measure with your wet bulb globe. So using just a thermometer to say, hey, it's 98 degrees outside or 100 degrees is not accurate. My one big strong suggestion is to use that wet bulb globe because it accounts for humidity, and then you can actually go kind of grade your re-acclimatization and de-acclimatization based on what your temperature readings are on a consistent basis, and also knowing the trends of your heat. So I can speak for Texas saying like our heat really actually starts in May and lasts until September. So you're looking at a very long summer months here compared to where in Pennsylvania, your heat may start in June, July, and you're pretty much done by August. So your time frames are going to be a little different. And so I would say, so the time frames are different and dependent on where you're located in the country. And then that's just speaking from my own personal experience with being in two drastically different states.
Yeah, great points in terms of the measuring the thermal load, humidity, taking accommodating for 70% of that wet bulb globe temperature. So if you're not in a humid environment, maybe the thermal load isn't quite as high. Basing your reacclimatization. Now, generally, it does take about 2 weeks. So there is still going to be a time period if there is an increased thermal load to be able to reacclimatize safely. But yeah, that's exactly we're dealing with the same things in Florida, certainly. Okay, so now here's a great question in terms of blood pressures, and you know, I'm curious to hear how you handle blood pressures, particularly if the blood pressures are elevated on the PPE. I know For me, if it's over 160 over 100, I am generally having them retest that same day. And then depending upon what the levels are, I may actually have them wait and have their blood pressure measurements tested with their athletic trainer, come back in, let's say, a week time period. Let's see what those blood pressure ranges are, essentially getting ambulatory blood pressure monitoring. What your cutoffs, how do you address blood pressures during the physicals?
So I have to agree with you, Brittany. It's the same kind of thing that I also do. So on the day of the PPE itself, if I find blood pressures elevated, I've seen some kids where they come because they're just anxious, or they just came right from practice or something like that, where their blood pressure will be a little bit elevated. I've seen 140 over 90, honestly, before in a kid. And what I do is, one, I repeat the blood pressure. And I actually have them, in order to effectively diagnose hypertension, it has to be 3 separate points in time. Now, the time points are variable between each physician. And if, for example, if I see a kid who has 170s or 180s, then yeah, I'm going to probably bring them back sooner, probably in the next few days, rather than wait a week or so. Versus somebody who's maybe in the 140s, then I could say, okay, you know what, come back in another week or so and see where you are. But in between, I have them keep a blood pressure log. So what I do is I say, hey, your blood pressure looks a little high today. It could be due to many factors. So I kind of reassure them first and say it may not be a big important thing, but what I would like for you to do is every morning before you, when you get up, before you brush your teeth, take a blood pressure. And usually they may have one lying in the house. If they don't, then I tell them to go get it from one of the pharmacies, Walmart, CVS, doesn't matter. But the most important thing is to utilize the instrument correctly to get that accurate reading. Or if they go to practices and see their athletic trainers and they're in season, then or are going to be in season because of practices, then I have them check in with their athletic trainer for 3 different points of time. And once I get those measurements, then I can say, okay, you know what, you are or you're not hypertensive, and then kind of go from there in terms of management. But I really look for those three points, and definitely would recheck on that day of the physical itself to see if it's really. And when I recheck manually myself.
Awesome. Yeah. So moving from the heat, we have a few other questions, kind of getting back to the PPEs, the COVID. There are a few states out there that have already put out information saying that they're going to be utilizing the PPEs that were done in previous years with updating of the patient history questions. What's your perspective on it, given the circumstances that are going on? What's your perspective on reusing those old PPEs with the updated questions? And then there was also another question here about essentially doctor shopping. People who are showing up at urgent care is not maybe necessarily saying all of their history, going through a physical that way.
All right, so kind of to address the first one, reutilizing old PPEs. Regardless of COVID or not, I typically don't. And the reason is because a lot of things happen either during season, or this kid plays in multiple other sports that does not get communicated to us. And unfortunately, not only from a physician standpoint, it's also from an athletic trainer standpoint. These kids don't really open up and tell us, and it's like pulling teeth to figure out what exactly happened during that time period and time frame. So, and I think it also happens from either from a high school standpoint of view and even a professional standpoint of view, and I've seen it on both ends with regards to that. So now, if I am going to take it with regards to COVID, we don't have very much information with regards to COVID and how it's going to be affecting sports. And if I have, and I always think about it from this perspective, if I was that parent whose kid needed to get an updated PPE, I'm all for it. I'd rather that a full one be done than here's some questions, here's this, and then be on your way. Because we don't know what exactly this virus is doing. We don't know its potential effects and implementations. We're getting data at this point in time. And when you're in this data phase collection, I think it's better to be thorough and just go ahead and repeat it all together. You can include the updated questions, but I think it's advisable to do that. Now, as far as doctor shopping goes, that's been a problem regardless of the pandemic or not. And of course, yeah, they definitely withhold information. But what can, I mean, if you are that physician and you document everything and you are that athletic trainer and you document everything, come liability wise from a medical legal standpoint, I think as long as you show the documentation, you show the conversations you had with that parent and the athlete, then I mean, regardless of whether or not they doctor shop, that's kind of out of your hands at that point. But you can at least control what you can from your standpoint of view when you see that particular athlete and parent at that point in time.
Yeah, I agree with that. And certainly if it's kind of out of your hands, but you're concerned that one of those athletes are maybe not necessarily getting managed appropriately, or something maybe a little bit out of the typical, would those be good ones, do you think, to bring those? Hey, you know, you're my team doc, let me bring this. Dr. Nuti, do you mind, you know, stepping in on this? Maybe pulling the player and the parent aside at some point and saying, hey, let's, you know, we ought to talk about this a little bit more. I'm here in the interest of the safety and health of your student athlete, and you know, I want what's best, and so we're coming at this from the same side. But maybe if this is the direction that things are going, that we're being forced to utilize old physicals with just those updated history forms, then maybe it comes more so onto you as the athletic trainer to kind of screen those and see who maybe you should reach out to the physician for.
Yeah, I think that's very reasonable to do with regards to that. So I would say that would, I mean, like I said, we as physicians definitely rely on you guys a lot because you are with those athletes day in, day out, and know those families really well compared to what we do know. So for us, we see these athletes in snap points in time, and you guys see them very consistently. So having that communication between you and us is a very key thing. And to kind of add on to the doctor shopping thing, I can kind of give you guys an example of one. I had a parent who brought in a child who was going to be an all-star softball player, and she sustained a concussion for the third or fourth time, honestly. And this parent did not bring this child in initially because even though the athletic trainer definitely documented and said, hey, she sustained a concussion, she needs to get a evaluation, the parent was like, oh, no, she's fine, she's fine, she's fine. The child is making things up. So had that difficulty with that parent in the beginning. And then it evolved to something where, as I was evaluating, this girl went into a post-concussive phase. Parent was not understanding why this was so, because not only did the parent delay the treatment on the child, but he thought the child was making things up. So then I had to get not only a vestibular rehab therapist, but also a sports psychologist involved with regards to her care. And the sports psychologist clearly evaluated this child and said, yeah, she's not making things up. She is actually in post-concussive. Again, the father is definitely adamant that she's not, and he actually had her go see a second opinion. And I kept writing and documenting and saying she is not cleared to return to sport. She is not cleared to return to sport. And father would obviously try to bypass me, and even try to get the vestibular rehab therapist to say like, hey, yeah, she's fine to go back. Doctor doesn't know what she's saying, kind of thing. Good point was that both the athletic trainer, me, and the vestibular rehab had talked about this case, and we were all unified on one front. So the father could not bypass either one of us. But I never saw the child again, and I definitely wrote in every documentation saying that she is not clear, she is not clear, she is not cleared. But I don't know if he ultimately got a different physician to get her cleared or what happened, because I never saw the child again. But that was one point to say that, you know, this father wanted to hear what he wanted to hear to get that child back, regardless of whether or not she had a post-concussive phase.
All right, well, thank you. Thank you, Dr. Nuti, and thank you to everyone who has attended. Actually, Dr. Nuti, if you can for a moment, can you turn your webcam on? I'm just...
Sure. Let me see how I can do that here. Please stop screen sharing. Do this. I don't know if it's showing up. Michelle, is there a webcam? Turn my webcam.
It would be on that small panel.
Uh-huh. Here. Let's have the camera first. Okay, everything's set. All right, it's on a small camera. Just says open system preferences. Not really allowing me. Sorry about that.
Not a problem. All right. Well, I want to thank everyone for coming today. From Dr. Michelle Henning here in Central Florida, from Dr. Nuti in Texas, we appreciate you guys' time, and I hope you have a great day and everyone stay safe.
Take care. Thank you.